Good morning, everyone. These are my disclosures. And the objectives today are to discuss the testosterone safety trials, which are, in essence, available now for the last year, since the FDA has become quite concerned about the off-label use of testosterone therapy in older men due to aging. We're going to discuss the most current data on cardiometabolic risk and testosterone, the Traverse cardiovascular study, and then present the current understanding of the relationship between testosterone and prostate cancer, which is the Traverse prostate cancer safety study. To put this in perspective, we reviewed all articles from 1940 to 2014 relating to testosterone and cardiovascular disease, and identified over 200 articles, and only 4 articles suggested increased cardiovascular risk with testosterone therapy. However, several dozen articles demonstrated beneficial effects of normal testosterone and cardiovascular risk and mortality, and we concluded that low levels of testosterone were associated with increased risk and mortality and cardiovascular disease, and that the severity of coronary artery disease was inversely correlated with serum testosterone levels. Back, you might remember, with the introduction of androgel by AbbVie in 2001, there was a significant marketing study, and testosterone became the fastest growing medication in the US, with sales growth exceeding 33% a year until 2013. 2013, 2014 were the release of 2 studies, the vegan JAMA study, which showed an increased risk of MI, non-fatal MI, with testosterone therapy, and the Finkel study, and PLAUS 1, which also showed an increased risk of non-fatal MI. These were observational studies that had significant statistical flaws, and the only randomized trial was the TOM trial by Basaria of frail elderly men who were given supraphysiologic levels of testosterone. It was a lower extremity mobility study, and these were not documented cardiovascular side effects. There were things like lightheadedness, dizziness. The study wasn't designed. So the evidence supporting the relationship between testosterone therapy and increased cardiovascular risk was, in essence, inconclusive. Yet the FDA Advisory Committee in 2014 and the FDA in 2015 noted that there was a weak signal of cardiovascular risk that emerged from these large cross-sectional studies, and that this needed to be in the label, which was that some post-marketing studies had shown an increased risk of myocardial infarction and stroke with testosterone replacement therapy. And thereafter, the prescriptions dropped significantly, and the FDA noted that there needed to be a response for a long-term safety study. So Traverse was this response to the FDA directive in 2015 that required manufacturers of approved testosterone products, AbbVie, which was the largest, to conduct a well-designed clinical trial to clearly address the question of whether an increased risk of heart attack or stroke exists among users of these products. This was a randomized, double-blind, placebo-controlled trial for men between the ages of 45 and 80, and what specifically included those men with cardiovascular disease or an increased risk of cardiovascular disease. The participants had to have 3 or more risk factors for cardiovascular disease. They had to be hypogonadal, they had to have 2 levels below 300, and have symptoms, and it was to include up to 6,000 patients, up to 5 years of follow-up. This was the study which was published in June of 2023, and based on the results of this study, in 5,246 men, testosterone was not associated with an increased overall cardiovascular risk, despite a higher incidence of pulmonary embolism, which was 0.9 versus 0.5%, acute kidney injury, 2.3% versus 1.5%, and AFib in the testosterone group. So you could see this was to be a double-blind, randomized controlled trial, 1-to-1 testosterone placebo gel, 1.62%, which was manufactured by AbbVie versus the placebo, and levels were to be drawn at frequent intervals, with dose titrations to be automated between 350 and 750 nanograms per liter. Now, for those of you who don't know, these levels were drawn the day after, 24 hours after men applied the testosterone gel. Normally, with a topical gel, we draw levels 3 hours after the application. So these levels were titrated when they were quite low, and the median level, which is the criticism of this study, was that the levels were only about 354 nanograms per deciliter. The primary endpoints were to be a composite of MACE, or major adverse cardiovascular events, including non-fatal MI, non-fatal stroke, and other cardiovascular causes. The trial was to be continued until there were 256 adjudicated major adverse events. Secondary endpoints included coronary stenting or grafting, prostate safety, and safe sexual activity and remission of depression. What you saw is that of 2,596 men treated in the testosterone group, an equal number in the placebo group, almost 60% discontinued the study drug, 1,593. And the mean duration of treatment was 22 months. The mean duration of follow-up was 33 months, so it by far did not come close to the ideal that those initial providers designated. These men were to be either, like I said, they had to have established cardiovascular disease or 3 risk factors. You can see that almost 50% were older than 65, 80% were Caucasian, 15.7% Latino, and 17% African American. They were obese with a mean BMI of 35, and the baseline testosterone levels were 220. Over 50% had pre-existing coronary artery disease, so this was a significantly at-risk group, and 45% of men had increased cardiovascular risk, and 70% were diabetic, 90% were hypertensive. You can see that the testosterone group and the placebo group did not separate. This was a non-inferiority study, and the testosterone group safety endpoint of MACE was 7%, that of the placebo group 7.3%. You could see that PE was slightly elevated, primarily in the form of with DVT, and that AFib was also noted, and acute kidney injury, and we don't really have an explanation as to why that was the case. So the limitations were adherence and retention was lower than most of studies and similar to other trials, and that cardiovascular safety findings were limited to this population, but not to men who do not have indications for testosterone therapy. So that this study should not be used as a justification for widespread prescription of testosterone to aging men. In conclusion, the TRAVERSE is the longest randomized placebo-controlled trial in hypogonadal men to date. It's among middle-aged or older men who had a history of established coronary artery disease and with a mean duration of 22 months, and there was no increase in major cardiovascular events. In terms of sexual findings, this was a sub-study, and Testosterone therapy was associated with significantly greater improvement in sexual activity than placebo, and improved hypogonadal symptoms and desire, and treatment was maintained at 24 months. You also know that testosterone is contraindicated in men with breast cancer or prostate cancer, and that this is part of the FDA label. So in truth, does giving testosterone to men with a history of treated or untreated prostate cancer increase the risk of recurrence or progression? This was answered by this prostate safety sub-study, over 14,000 patient years of follow-up in 5,204 men. In this randomized trial, the incidence of high-grade or any prostate cancer, urinary retention, or invasive BPH procedures were low, and the incidence of any high-grade prostate cancer in the TRT group versus that in placebo group did not differ significantly between groups. So this was a negative result. And to summarize the TRAVERSE trial's summary, the cardiovascular MACE was negative, PE was equivocal, prostate, there was no incidence of prostate cancer, no incidence of BPH LUTS, sexual function improved, libido improved, depression improved, bone fracture did not improve in this short study, anemia did improve, and diabetes did not improve. Low testosterone is associated with increased cardiovascular risk. Current data support a low CV risk in men with testosterone therapy and improvements in cardiometabolic parameters. And normalization of T levels may reduce the risk of death, MI, and stroke, and there's no data currently supporting an increased risk of prostate cancer occurrence or progression in men on testosterone therapy. Thank you.